Hi friends, I'm Dr. Mukesh, Treasurer, IAP Neocon 2021 Organizing Committee. I have proud privilege of welcoming you all to the program of IAP Neocon Learn from the Legends, an international bi-monthly webinar series. For the 22nd webinar of this series, let me first welcome our distinguished speaker of today, Professor Koert, John Hunter Children's Hospital, Newcastle, New South Wales, Australia. Sir, welcoming you.
Thank you.
He will be talking on cardiovascular compromise after birth asphyxia. Hearty welcome to you, sir. Next, let me welcome our moderators, Dr. Dinesh Tomar, Secretary General, National Neonatology Forum, India, and Dr. Kishore Kumar, Cloud9 Hospitals, Bangalore.
Good evening, friends.
Today we have around 3,500 participants from 65 countries. I, on behalf of organizing committee, sincerely welcome you all for the webinar. Have a wonderful learning experience. Thanking you. Over to the moderators for further proceedings. Thank you, sir.
Good evening, everyone. I have great pleasure in welcoming Koert Diwal from Australia. We all know that birth asphyxia is a problem which we don't want to see, and prevention is better than cure in birth asphyxia especially. But once birth asphyxia happens, we all know that everything gets compromised, more so the cardiovascular compromise. And Koert Diwal has done incredible amount of work in this area to show that functional echocardiography can pick up the cardiovascular compromise in various ways. And cardiovascular compromise can be a cornerstone of various problems in the birth asphyxia. Though we have learned how to protect the brain with our therapeutic cooling, we can actually reduce the morbidity by taking appropriate precautions to prevent the cardiovascular compromise. And we have definitely going to be learning a lot of things which we can do better. And for that, we will request Dr. Dinesh Tomar to introduce Koert Diwal so that we can start without further undue delay. Thank you.
Thank you, Dr. Kishore. And good evening, dear friends. Greetings from National Neonatology Forum of India. First of all, I want to thank the office bearers of NNF Kerala, Dr. VC Manoj, Dr. Vishnu Mohan, and the organizing team for inviting me as a moderator to this enlightening session. I have the pleasant duty of introducing Dr. Koert Diwal. We all know that he is a world-renowned figure in neonatal hemodynamics and cardiac ultrasound. Thank you, sir, for sparing your time for this session. To enlighten our viewers on Dr. Koert Diwal, he was born in Netherlands and was trained as pediatrician and neonatologist in his home country in Dutch Caribbean with a postdoctorate training in Royal Prince Alfred Hospital in Sydney. There he mastered functional echocardiography. His interest is in neonatal hemodynamics and cardiac ultrasound. He also completed a PhD in central blood flow measurement at University of Amsterdam, Netherlands. Currently, he is working as a consultant in John Hunter Children's Hospital in Newcastle, Australia, where he continues his research in neonatal hemodynamics and novel echocardiographic techniques. Over to you, sir.
Thank you very much for this really kind introduction. I will share my screen. Just let me know if this all comes up. Again, thanks for inviting me to do this talk, which is about cardiovascular compromise after birth asphyxia. And even though the introduction might seem that I still think we can still learn a lot, but there's still also a lot to study about this particular, actually frequent event. So I have no real conflicts of interest to declare, except that I explain a lot of my clinical cases, or try to explain them by using physiology. So you will see some physiology slides and comments coming through on this talk. And I think to set the scene and start off, I think this is a familiar case. This is a term baby, unexpected, flat at birth, extensive resuscitation with cardiac compression, 3 doses of adrenaline, and the EPCA scores are pretty poor. 0, 1, and 2 at 10 minutes, and then 5 at 15 minutes. And the team calls and says, look, we're on our way to the NICU, set up the ventilator, umbilical lines, the AEG, and the cooling machine. But interestingly, in that sort of initial step, not everybody asks themselves the following question: should we actually prepare cardiovascular support? And what kind of hemodynamic abnormalities would you expect when you have a baby like this? So this is probably the part where my talk will be mostly about. Should we prepare for cardiovascular support, and what can we expect? I think most of us are familiar with this particular study from the late 70s by Farm. It's about hypoxia-ischemia. It was a bit of a gruesome way of measuring, but what he did, he took monkeys and he took a bag over their heads when they were just born, and then made them asphyxiated for 10 minutes, and then they resuscitated these monkeys. But it has given us a lot of information about the hemodynamics during these kind of severe hypoxia-ischemia events. We know from the breathing there is a primary apnea, and then the gasping starts till there is finally sort of a terminal apnea. And only when you then start resuscitation, the gasping comes back and then finally turns back into regular respirations. But the measurements on heart rate and also arterial pressure are actually quite important. If you look at the hemodynamic effects of hypoxia, you get a reduced heart rate, a reduced vascular tone, and in later studies where they repeated this and look at also at the contractility, also a reduced contractility of the heart. And they all starting to come back during that resuscitation moments and thereafter. So if you look at it on an even deeper level, if you look at it on the cellular level, then there's actually 2 components happening during hypoxia and ischemia. So the first part, during hypoxia, you look at the cell on the inside and the mitochondria, they don't get enough energy. So there is an impaired ATP production. That's where it starts with. And that gives a decreased intracellular pH. And to get that pH out, the cell wants to sort of excrete its hydrogen ion to the hydrogen-sodium channels. So the hydrogens will go out, but it'll come at a cost for increased sodium influx. And because the cell doesn't have much ATP, it can also not excrete its calcium. And these things are essential if we go to the second phase of hypoxia, is when we're starting to resuscitate, which is then actually the reperfusion. So the hypoxia gives ATP depletion, cellular acidosis, and calcium overload. But then during the reperfusion, some paradoxical things trying to happen. First, the cell is actively trying to normalize its intracellular pH by pumping out way more hydrogen. But in return, the cell will get way more sodium. And because the sodium is exchanged with calcium on the regular channels, you also get more calcium influx during the reperfusion phase. Then there is separate to that the generation of reactive oxygen species, or ROS. And so this is called the oxygen and calcium paradox of the reperfusion phase on cellular level. So even though reperfusion gets rid of the hypoxia, it still generates its own separate point of damage. And if you put that into sort of a timeline in hypoxia here on the x-axis and tissue injury on the y-axis, then different kinds of tissues will have different viability thresholds. For instance, we know that the brain is way more sensitive to hypoxia than, say, muscles, and has a different viability threshold. So if you're placing this in blue, the ischemic component, the longer it takes, then all of a sudden you're sort of crossing that viability threshold, and then this is where tissue injury occurs. And the longer you stay in hypoxia, the more significant tissue injury will occur. But there is that second phase as well, which is the reperfusion component. Now, reperfusion by itself is probably not killing off tissues, but it is added towards the ischemic component. So if you add them all together, then the ischemic reperfusion in tissue in total is actually much higher than its individual components by itself. We know that then after the reperfusion phase, it then continues into cell death. latent cell death, secondary cell death, and even tertiary cell death can happen at different phases after a hypoxia-ischemia insult. Some cells are programmed to die away, some die from some toxins, some die from inflammation, some die from the oxidative stress, and then secondary, you have mitochondrial failure or seizures, and way later when the brain starts to remodel itself, you get all sorts of different kind of damage. And in this short time frame, 30 minutes, 6 to 12 hours, that's when we have found some opportunities to at least create some preventive measures. We have some different medications which are all still being tested, of which one is going to be the best, erythropoietin and some other exotoxic inhibitors. But the most important sort of treatments we have to prevent that latent and secondary cell death is therapeutic hypothermia. This is an example of one way you can give therapeutic hypothermia, but there's different ways you can sort of apply this to a baby. This therapy itself has its own effects on the hemodynamic situation and the sort of, intricate balance between reperfusion and tissue injury. Hypothermia gives cerebral redistribution, gives vasoconstriction, sinus bradycardia, and eventually also a fall in cardiac output due to diminished demands, but also due to direct effects of hypothermia. So us as clinicians have to work in this realm of this balance where we have to find the optimal cerebral perfusion. So how do we do that? If we want to monitor this ischemia-reperfusion phase, how do we then give treatments to find sort of the optimal cerebral perfusion? Can we maintain optimal cerebral perfusion? And can we manipulate cerebral perfusion into the optimal range to help improve outcomes? Well, first then you have to question yourself, can we measure cerebral perfusion? And the answer is yes, and I will go to some examples later. But probably the second question is a little bit harder. What is the optimal cerebral perfusion after birth asphyxia? And particularly at the end of the talk, I'll try to give you some examples of where we probably should go, but a lot of new research is needed in this particular area. So can we measure brain perfusion? Yes, we can. The most elegant way, I think, to measure brain perfusion is measuring at the brain. So there's a device called near-infrared spectroscopy, or NIRS, usually abbreviated, which measures the content of oxygen attached to hemoglobin, just like your saturation probe, but in a regional manner. So if you place it on the forehead, you will measure regional cerebral oxygenation. And you can make some sort of assumptions on the perfusion which are taking place. NIRS has been on the market commercially for, I would say now, 2 decades, but this slide shows the amount of studies which specifically looked at NIRS and birth asphyxia. And the different colors reflect different machines, and unfortunately, as we also have seen on our ventilators, that for the same parameters, different manufacturers use different terms, and sometimes they were very confusing, and they made reading the data sometimes a little bit complex. But after all, and if you get a little bit into all the names, they give all these different sort of parameters. The most commonest measured parameters is regional cerebral saturation, with different kind of abbreviation. And this is an older study from 2013. Petro Lemmes did a study in 39 infants with HIE, moderate to severe, and looking at just what happens every the first 3 to 4 days. And she found some very interesting results, and these are being consistently found in the literature. The babies with adverse outcomes, which was either death or neurodevelopmental impairment, they actually had a higher saturation than the babies who had a good outcome. And that sort of differentiation took place sort of between 12 and 24 hours and continued throughout 3 to 4 days. This is important because this probably means that the brain is not regulating itself properly to deal with this increased amount of perfusion. So there must be some form of autoregulation in the brain which has been impaired in these particular children. So if NIRS has to deal with autoregulation, you probably then also need an added information to better interpret the data, which is blood pressure, and particularly continuous blood pressure together with NIRS is a very good combination to get us some information about brain perfusion but also about cerebral autoregulation. Let me explain that cerebral autoregulation in a little bit more detail. This is Gordon Greeson's simple explanation where the blood pressure is on the x-axis and the cerebral blood flow is on the y-axis. And autoregulation happens within that plateau where it's all straight. So at that point, the vessel diameter, even if blood pressure would drop, would actually increase in size so that the total amount of perfusion in the brain would still be the same and stable. There is, of course, a lower limit of autoregulation that if the blood pressure drops below that, then the vessel diameter would still get smaller. And there's also, and I think that's just as important, an upper limit of autoregulation. That when the blood pressure is too high, the vessel diameter gets too big and there's too much perfusion going to the brain. So different investigators have different ways of measuring this, but it usually is a combination between blood pressure and some form of NIRS parameter. This is an example from Flora Wong from Melbourne, who used mean arterial blood pressure and NIRS measurements. And you can see here an example on the left of intact autoregulation. So even if blood pressure varies quite a lot, if you can see sort of just past that middle bit, the NIRS trace hardly changes. So this is intact autoregulation. However, here on the right, though, when there is changes in blood pressure, you can see almost simultaneously changes in the NIRS trace on the cerebral saturation as well. So this is impaired autoregulation, and generally not a good sign. So a series of investigations have been done and tried to work this out in infants with hypoxic-ischemic encephalopathy. This is a study by Massaro from America, which looked at those combination or the correlation between the blood pressure and the NIRS and called it the pressure passivity index. So the higher PPI would regulate or would indicate a higher or more impaired autoregulation. And they looked through that whole process again for a couple of days and see what happened. And they found that there were various moments where autoregulation was more impaired in patients who had an adverse outcome, here in red, versus the patients who had a good outcome in black. And what was quite interesting, actually, it happened not at that early phase, it happened sort of a little bit later, and particularly when rewarming started. This group of investigators by Howlett looked at 24 incidents with HAE, and they looked at the same sort of data, but they named it a little bit differently, but they did the same thing. But what they did for each individual patient, they looked at what would be the best blood pressure, where blood pressure correlated the least with cerebral perfusion, which would indicate autoregulation. And then with that, they looked at, okay, let's look at MRIs of these children after the end of their stay, so day 7 to day 10, and looked how much injury they had on different areas in their brain. And what I'm presenting here is the thalamus, the basal ganglia, and the white matter. And they looked at how many times these children were below the optimal range of blood pressure, within the optimal range, or above the optimal range. And the results were complex and actually a little bit disappointing. You would expect that if you have no injury or mild injury, you'd be mostly within the optimal range, but that was actually not true. They spent very limited time within the optimal range, and most of the time they spent above the optimal range. And infants with moderate to severe injury on the MRI spent actually most of the time within their optimal range and still a significant amount above optimal range. So although a fantastic study, it has actually confused us about what will be the optimal range then to prevent injury. I will get back to that a little bit later. So cerebral autoregulation, or particularly impaired cerebral autoregulation, and if you read papers about it, it is not that easy read. The data can be somewhat difficult to interpret. It is certainly not a continuous phenomenon. It can be on, it can be off, and it can happen, you know, within hours of changes or different kind of things happening to the children. In most studies, though, it did occur mostly during the rewarming phase, and that's important. Impaired autoregulation was associated with adverse outcomes, but again, not always. So there must be other factors that play a role. For instance, think about CO2, your glucose, your calcium, or maybe also our treatments. So if we can't measure everything and interpret everything with NIRS, which can look at cerebral autoregulation, or with blood pressure, what else can we use to look at the actual perfusion? So NIRS has also another limitation. It takes a lot of assumptions about perfusion and doesn't actually measure perfusion. It just measures the oxygenation. If you want to measure pure perfusion in the brain, you need very invasive kind of techniques, or maybe you should measure one step lower, as I call it. Maybe you should measure at the heart. So why don't we measure some more cardiovascular function? You can do it with different kind of techniques, but the ultrasound is what I'm going to talk about most, how we can tell something about brain perfusion. Different aspects of cardiovascular dysfunction can be measured clinically with an ECG, biomarkers. This is new technique, which is called electrical velocimetry, which is quite interesting, and echocardiography. So clinically, we know that cardiovascular dysfunction is actually quite common. This is data from a systematic review from Jacobs, which showed that in the studies, this is in the randomized trial, hypertension defined as a mean arterial pressure less than 40 happened in half of the patients, and a third would receive inotropes for their hypertension or poor perfusion. About 1 in 5 would develop pulmonary hypertension, certainly now in the area of cooling, and renal impairment and hepatic dysfunction, which can have an effect on your volume status or how medications work, would happen in at least 1, maybe 2 in 10 as well. The earliest studies before ultrasound was widely used a lot of ECGs, and some abnormalities could certainly be found in infants born after birth asphyxia. They usually have a wider QRS complex, elevated R waves, ST depression could be found, and right ventricular hypertrophy. But they looked carefully and they wondered if this was associated with outcomes, and actually they could not find a good correlation with ECG abnormalities and clinical outcomes. So that was a bit disappointing. So it's probably not recommended to do routine ECGs on these babies, but what I do recommend is to look at the heart rate. There's 3 studies out which show exactly the same sort of findings, and this is one I showed from Montaldo. They looked at 64-term infants with moderate to severe HAE and whole body cooling, and they looked at the heart rate or the RR interval sort of throughout these 3-4 days. And this is what we could see at the bedside, and I bet you have the same experience as well. The infants who had an adverse outcome, death or moderate severe disability, had a higher heart rate at 12 hours and 24 hours and for the whole period of cooling compared to the children who had a good outcome, which is shown here in black. And I think the explanation is rather simple. The more brain damage you have, the more likely you will also have autonomic dysfunction. So how the brain talks to the rest of your body, how it controls its vessels, but also its heart rate. So the normal response to cooling, if your brain is well and you have no autonomic dysfunction, would be to have a bradycardia. But these children with adverse outcomes and more likely having more brain damage couldn't bring their heart rate down as was expected from a normal response. So this is autonomic dysfunction. Most of us would use biomarkers in babies after severe HAE, so do we. You have creatine kinase, which is released after heart and skeletal muscle damage, so that's maybe not as differentiating. The natriuretic peptides are more released with increased atrium and ventricular wall tension, and maybe more appropriate for heart failure than any other disease, but the cardiac troponins are released with reversible and irreversible cardiomyocyte injury, and probably the most commonly used. And there are quite a lot of studies on using these biomarkers. I found over 30 cohort studies which all found the same thing. Cardiac troponins, particularly those, are an important marker of the severity of the hypoxia and ischemia event that happened. However, if you want to then use that to promote targets to treatment, that couldn't prove. And it's because troponins have a wide range of normal values. Different studies use different immunoassays, so it makes comparisons in between a bit difficult, or do a systematic review of a diagnostic test. But what's probably also important, that the levels can be affected by common HIE treatments. Think about adrenaline, which you give during resuscitation, and even cardiac compressions can raise your cardiac troponin levels. So we certainly would take them at birth to say something about the severity, but we won't use them to target treatments thereafter. This is a study by Wu, which is from Series group, and they used a technique called electrical velocimetry. So what it does, with carefully placed electrodes, you can measure impedance differences, which measures which is significantly different between fluid and air, but also between more fluid and less fluid. So you can actually depict the trend of flows, not the absolute amount of flow, going from the lower end to the upper end, so into the systemic circulation. The red dots are showing the co-AEV, that's the electrovelocimetry sort of signal during before rewarming, during rewarming, and after rewarming. And as expected, you would see a slight rise in heart rate, but also in this electrovelocimetry sort of trace. And the good thing about this kind of technique, it's non-invasive and very easy to use. The disadvantage, I guess, you don't get any detail further about blood flows and how the heart works. But I do think we're going to see some more studies using this particular technique. Now, my expertise and experience lies most in echocardiography. And there's some important lessons to be learned about what parameters to be used, in particular this population. This is a simple representation of the left ventricle with the apex at the bottom and the base at the top. And the most commonest used measurement in, well, in neonatology, in any field, is actually M-mode measurements of the heart. Adult services hardly use M-mode anymore, but neonatology still clings on to this particular parameter. And what it does, it measures radial function, which means the squeezing of the heart in a radial fashion, and can give parameters like fractional shortening and a calculated ejection fraction. The heart, however, works way more in a longitudinal area, so base to apex function, and more of its function is in that particular aspect. And you can measure that with M-mode, TAPSE and MAPSE, and I'll show you some examples soon, or with tissue Doppler or speckle tracking are probably the most fancy sort of parameters you can use. And the last one, which is slightly different, you can measure volumetric changes, so how the inside of the heart changes during systole and diastole, which can give you parameters like stroke volume or Simpson's ejection fraction. So this is an example of a radial function M-mode fractional shortening, where you measure the distance between just in between the mitral valve leaflets and the tuberculation, sort of in between, and that's where you're going to measure perpendicular to that the diameter in diastole and in systole, and then using this Teichholz formula, which uses a lot of that diameters in it, you can measure fractional shortening, ejection fraction, and stroke volume. As I measured before, I do think longitudinal function is much more important because it looks at the base to apex function of the heart, where usually 60 to 80% of cardiac function hides. You can measure it in the left and the right, which is another advantage. You can do a TAPSE, which looks at displacement of the annulus going upwards towards the apex, or you can measure it at the other end, which is called MAPSE, again, displacement of the annulus going upwards towards the apex. And there are normal values available in different populations and different size babies. Bit more modern is using tissue Doppler, which instead of measuring displacement, it's measuring velocity of the annulus going upwards. And on the left, you see the color Doppler image. You place your pulse wave either on this middle bit or individual on the free walls, and you get this typical sort of pattern, which you can see on the right, where first you see the valve close, that's the mitral valve closing, and then you get your S wave, so the velocity upwards during systole, and then you get your isovolumetric relaxation, and then you get your E wave on the diastole, and then the atrial contraction sort of comes at it before the isovolumetric contraction still starts. This study by Wu, I think, opened my particular sort of ideas about, now let's not use M-mode fractional shortening anymore. They looked at babies with severe asphyxia, mild asphyxia and control, and when using fractional shortening, they could actually not find much of a difference between these three groups. However, using the technique in a longitudinal session using tissue Doppler, they found significant differences between the control and the asphyxiated babies at 24 hours, at 48 hours, and even still at 72 hours. Measuring volumetric changes is rather simple. You take a good image, usually an apical 4-chamber view, and you look at the size of the ventricle in systole and diastole, and then the machine can calculate stroke volume and ejection fraction. You can do it at the right side as well. It's a little bit harder because the right side sort of bends itself over the left, and the 4-chamber view can be a bit tricky to get for the right ventricle. That's why they don't use volume for the right ventricle, but they use area changes, because otherwise you would just duplicate all the errors which you measure. That's what you see on the left, but on the right is what I think a lot of us use to measure blood flows. So you measure a annulus, or a diameter where the blood flows through, and then at the same point you measure with your pulse wave the velocity time integral, which we can see here on the right. You can do it at the right ventricle, you can do it at the left ventricle outputs, and you measure cardiac output. These VTI measurements, they're actually not cardiac function, they are the interaction between the heart and the vessels, which can give you some additional information on top of cardiac function itself. And this is a good example. This is Kumarji, who did a study in 2012 looking at a significant portion of babies with HIE. And he used flow in the Vena Cava superior. And the Vena Cava superior comes back, is a venous vessel, but it sort of supports back 80% of the blood flow, which is coming from the brain. So I think it's a good proxy of venous return from the brain. And he found exactly the same as Peter Lemmers found with his NIRS measurement, that babies with an adverse outcome, again in red, have a much higher SVC flow throughout this whole period than babies with a good outcome. So this again points out that a lot of babies with adverse outcome have some form of autonomic dysfunction and cannot control the amount of flow going to the brain. Now, most of the ultrasound measurements which have been done in asphyxiated babies have been done sort of at 24 hours and sometimes at even 72 hours. But this is probably one of the first studies from Marvin Sego in Melbourne, who looked much earlier, approximately 5 hours after burst asphyxia. And his findings were astounding. If you look at cardiac compromise, either measured with flows or with TAPSI or FAC, moderate cardiac compromise was found at least 3/4 of the babies. Luckily, severe cardiac compromise wasn't found as much, between 12 and 18% was found. But this does indicate that cardiac compromise is very common in babies after burst asphyxia, particularly early on, and probably needs a bit more of our attention in those early phases as well. This is Regan Giesinger from Canada, where she looked at a large cohort, 53 infants, and she found at 24 hours of age, and she found that actually it's not just only cardiac dysfunction, it's also right ventricular dysfunction, which can be independently associated with adverse outcomes. She measured right ventricular function with TAPSI in the middle and fractional area change on the right. And as you can see, there was some overlap, but there was a significant difference between these values in the babies with a normal outcome or with an adverse outcome. And she couldn't find that same difference, but you can see on the left with an ejection fraction, Simpson volumetric changes, where the normal and the adverse outcomes had sort of the same range, which was quite interesting. So cardiovascular compromise after burst asphyxia, after I've summarized it, then I think early cardiac dysfunction, PPHN, and hypotension are common findings which you can find on either ultrasound or other measurement tools. Autonomic dysfunction is common, including loss of cerebral autoregulation, And high cerebral perfusion, however it was measured, NIRS, blood flows, heart rates, was associated with adverse outcomes. However, there's some limitation, and I think the main limitation is there's actually limited data in the first 6 to 12 hours after birth. I think we need to collect more information on what's going on in that particular phase very soon after the reperfusion. I'm going to summarize this summary, but now with a schematic diagram. And I sort of made some small adaptations from an excellent overview paper by Pang in seminars only two editions ago. So it all starts with hypoxia. After hypoxia, it will lead to impaired cardiac contractility, PPHN, and loss of vasomotor tone, so hypotension. Acidosis itself has an additional effect on impaired cardiac contractility and particularly PPHN, and maybe a little bit of loss of vasomotor tone. But all three of them will lead to a reduced cardiac output and reduced blood pressure. And that in itself will lead to impaired cerebral perfusion or abnormal cerebral perfusion, mostly high after 24 hours of age, but we're not quite sure what happens in the first 24 hours of age. And then PPHN and loss of vasomotor tone could have an independent effect on this impaired cerebral perfusion. So if you look at this complex situation, you also understand how difficult it can be to get it right or to measure it in the first place. To make things more complex, we do hypothermia, which has its own effect on cardiac contractility and PPHN. And then we give all sorts of medications. We give catecholamines to treat hypotension. We give sedation and antiepileptics, which can all have their individual effects, predominantly on vasomotor tone and cerebral perfusion. So if we want to manage cerebral perfusion, the question I ask myself is, okay, what should then be our thresholds for blood pressure, for cardiac output, or cerebral NIRS parameters to optimize outcomes? And to be honest, the short answer is, we don't know. But there is at least some progress happening, which I think we should all sort of copy paste and see how we are doing and performing in this particular area. And one was a very simple survey. It was a survey in 71 NICU centers, mostly in America. And they asked the clinicians, okay, so how do you define a low blood pressure in which you want to do something? And as you can see, there was a huge variation between centers. The mean, some use mean arterial pressure, and it varied between 30 and 45. Some use systolic pressure, which I personally prefer as well, and use the 3rd percentile, or some say 50, and some say 10th percentile. And some added low COS, so low cardiac output syndrome, into the definition, but even the definition of LCOS was different per center. And even if we can sort of agree on which sort of parameter we're going to strive to treat or to maintain, what treatment should we use? So which vasopressor or inotrope should we use? Well, we actually have very limited, surprisingly limited randomized controlled trials in neonatal hemodynamics. And cardiovascular dysfunction after HIE is probably the poorest studied of them all. So dopamine has been used in one randomized trial, 14 infants, it was very early in the 80s, with birth asphyxia. But when you look at that paper, all those babies actually had a normal blood pressure before they were randomized. There's one cohort study with dopamine in 6 infants with severe birth asphyxia, and they found that indeed dopamine can increase the pulmonary arterial pressure more than it does the systemic arterial pressure, which is not a beneficial thing if you also have a risk of PPHN. Dobutamine, no randomized controlled trials. There was only one study in 6 infants with severe birth asphyxia where it showed it can increase stroke volume. So we have very limited randomized data to go on. There are some cohort studies, but also not that much. But I think to me, the best overview is this one, is animal data. Joint sort of summarized in Frontiers in 2018 what medications we use and how they have performed in animals after birth asphyxia. And they looked at the 3 domains where we want to work in: improve contractility, improve loss of vascular tone, or treat PPHN. And as you can see, if you just have loss of vasomotor tone, dopamine will be most effective. If you want to treat PPHN, nitric oxide is most effective. If you want to improve contractility, dobutamine was most effective. But there is medications which have, various effects on maybe all three domains. And the one right in the middle is epinephrine. So I guess if you don't know, epinephrine might be a good sort of starting point and to at least have some action on all these three components. There's maybe a better way of doing it, and that is indeed using bedside ultrasound to target your treatments. And in that large survey in America, they compared data from centers who did have bedside ultrasound available to them versus centers who didn't. And they found a couple of things, a couple of differences which were interesting to look at. One, in the centers that did have bedside ultrasound, there was an early ultrasound done for hypotension to make decisions about if you want an inotrope or a vasopressor. There was a lower use of medication that increases the pulmonary arterial pressure, basically meaning a lower use of dopamine. The first line vasopressor was lower. They use more inotropes than vasopressors as a first line. PPHN and the assessments of it and the findings of it were incorporated into their targeted treatments. And probably at the end of it, if you add that all up and you have those services available, there were less babies referred to ECMO than if you had ultrasound sort of there versus the ones who did not. So if you take this data, which is not randomized, but based on experience and growing sort of small quality improvement projects, where at the end it leads to a targeted treatment support regime, then you can do it in this particular way. You can look at blood pressure, oxygenation, ultrasound, and combine these three together to give you a likely physiology. And then you can choose your treatments and you have some suggested agents. For instance, if blood pressure is low and oxygenation is normal and the ultrasound is normal with function, then your likely pathophysiology is loss of vasomotor tone. So your treatment will be a vasopressor, and dopamine will be very suitable for that in this situation. If your blood pressure is low, your oxygenation is normal, but you have left ventricular impairment, which is a common finding in these particular baby, then the impaired cardiac contractility is probably the most dominant pathophysiology in this situation. And the treatment would likely be an inotrope. And the most used agent in those situations likely dobutamine. If you have reduced oxygenation and PPHN on ultrasound, then you need to probably treat that dominant physiology first. So you can use a vasopressor or you can use nitric oxide. But you also have to consider to optimize your ventilatory setting and your lung inflation, or you can add some noradrenaline as a vasopressor. Then if it all comes complex and there's differences between left and right, if left ventricular impairment, but there is also PPHN is more dominant, please treat that first before you start treating the PPHN, usually with an inotrope. But if right ventricular impairment is your dominant one and you have PPHN, then you can choose for inotrope and nitric oxide, so to treat that and get perfusion better. So this form of targeted treatment is my preference as well. And it takes serial ultrasounds. You have to do it repetitively to come to a sort of a decision. And with each step, you check yourself and see what happens. You check yourself what happens after an hour, after 2 hours, to see how the response was. So if I have to summarize what I would do in the early phases, 0 to 6 hours, I think the most important step is to correct the hypoxia, which most people easily do. And then I try to restore optimal perfusion with a gentle treatment of hypertension and low blood flow, because we've seen from the studies that ramming the perfusion up to quite high levels is probably not beneficial. So I target low normal blood pressure and blood flows and a low normal base to apex longitudinal cardiac function in slow incremental steps. In the later phase though, between 6 and 72 hours and even a little bit beyond, keep your eye out for autonomic dysfunction. It's a very important parameter, and you can actually do that at the bedside. You don't need that much fancy tools, because if you're doing some examinations on your baby, like a pupil examination or suctioning or a nappy change, the normal stress response should be an increase in heart rate, an increase in blood pressure. And if you would have NIRS measurements, they would be stable. And there is an impaired stress response or autonomic dysfunction if you more see that the heart rate actually goes down and the blood pressure starts to fluctuate. In those situations, if you had a NIRS, you would see an increase in cerebral perfusion during those moments. And Campbell and his group, they found out that if you look at that and you make an autonomic dysfunction index, then there was a very strong correlation with autonomic dysfunction and moderate to severe injury or death in these particular populations. If autonomic dysfunction is present, that means we need to be careful. Minimize blood pressure fluctuations, which is minimal handling. If possible, which is harder, avoid high blood pressure and a high blood flow. But also important to realize you should expect further changes during rewarming, so you should prepare yourself during that rewarming phase. This is an older study from Gebauer, which looked at cardiac output during rewarming. They found that the infants who are already on dobutamine, which is the gray boxes, versus the children who are not on dobutamine, which was the white boxes, they increased their cardiac output way more. So this is probably not beneficial, especially not in the babies who have autonomic dysfunction. So it will tell you to wean your cardiovascular medication before or during rewarming with regular checks. So the whole management of cardiovascular dysfunction in this situation, I have to summarize and also conclude that the optimal hemodynamic care of infants after birth asphyxia is not well studied, and we don't know exactly what to do. I do think we should initially be careful and then later on take special attention to autonomic dysfunction. In that early phase, when most of the problems still occur, the hypoxia can be ongoing, particularly due to PPHN, then targeted treatment can be achieved, particularly with serial bedside cardiac ultrasounds. This will give you more insight in the actual hemodynamics and the effect of our treatments, and that by itself could hopefully help improve outcomes. What happened to the case? This was a rare case and had actually quite rare findings, which I like to share with you. This is 3 hours post-birth asphyxia. The baby had hypertension, poor perfusion, and ongoing hypoxia. And we gave it some dobutamine on 15 and ended up 15 microgram per kilogram per minute before the flows improved. Once the heart started to function a bit better, we got this on ultrasound. So this is an apical 4-chamber view, not inverted, the right ventricle and the left ventricle. And particularly if you pay attention to the left atrium and the left ventricle, you can see that the left atrium is full and is not moving as much. And also the left ventricle looks a bit odd in its movement. One thing you can do, you can measure this kind of movement, of course, with tissue Doppler, but in this particular situation, we used a form of speckle tracking, and we looked at the vectors of this heart, the vectors and the velocity. They point towards the direction and what velocity it has. And what we saw in this particular situation is that the movement was very abnormal. Normal movement should be a butterfly that should come together both in equal ways and then go outside. As you can see here, this is more, they're all pointing to the same direction during the cardiac beat. So this was a myocardial infarct. Now, again, that's a rare finding in asphyxia. It is described every now and then. It's more common outside birth asphyxia, but this was a special finding in this particular case. So this was my last slide, and I want to thank you for your attention, and I hope we can have some questions and discussion.
So thank you for a wonderful presentation, and we were all mesmerized by your slides and presentation. So we have 3 questions in chat box, and few of them you already answered. Like one person has asked that, do you do echo in all the children who are cooled? All the children who are taken up for cooling?
Yeah, I see the questions. So the top question is if cerebral blood flow is different in preterms compared to terms. It is.
The first question is by Dr. Parson. Is there any difference in auto-regulation of cerebral blood flow in terms versus the preterm babies? And how does it impact your management?
Yeah, no, there is differences in the amount of time a preterm baby is in auto compared to a term baby because the autoregulation system has to mature. So preterms are way less in autoregulation than they are. And in preterms, it's probably very important in the development of IVH. That's a complete new talk, so we're not going to go into that. Now, HIE in prems, I think, is more difficult to manage even because they have their transitional problems on top of that. So autoregulation is different. It's not well matured in prems. Do we use it during management? No, it's still in a research kind of fashion.
Then we have choice of inotropes. I think this you have explained. What is your choice of inotrope for PPHN with poor contractility and hypotension? That slide you have shown clearly explains that.
So if it's just left ventricular dysfunction with PPHN, my preference is still dobutamine. I think dobutamine and milrinone are very comparable to each other in their effects. You could argue that milrinone has a little bit more afterload reductions, but I find the disadvantage of milrinone that if you start it, it will take 6 hours to, and particularly if you have systemic hypotension, dobutamine gives you a little bit more playroom to titrate to. So my choice could still be dobutamine first. If you feel that the hypertension
do you do
is also related. Oh, noradrenaline, yes, absolutely. Yeah, so noradrenaline I use in babies where there is reasonable contractility, but still an hypotension and PPHN.
Then Dr. Pari has asked that has heart rate variability been studied in HIE population? If so, can this allow us better understand the babies who could have more issues with autoregulation?
So the study from Montaldo I showed you is actually heart rate variability. We looked at RR ratios, and there's another group of investigators who looks a little bit more in depth to actually heart rate variability, but they came to the same sort of conclusion that it is the total heart rate, so the actual RR interval, which was more important than heart rate variability. I'm not quite sure if you can use heart rate to study autoregulation. I think you need blood pressure to give you a better answer.
Then Dr. Alpha has asked that when do you extubate these babies? Within first 72 hours or after finishing 72 hours?
That's interesting. So we would also, if the baby is respiratory improving and hemodynamically stable, we would also extubate these babies. But I indeed heard that some would want to continue them on a ventilator. Look, I guess what is important is that during that whole period, whatever gives the least amount of blood pressure fluctuations is probably the best. If you can do that on a mechanical ventilation, you can certainly do that. If you feel you can do that much better with a spontaneously breathing baby on CPAP, then that would also be good. We have more experience with a CPAP or just high flow in these particular situations, then we feel that that gives the babies more calm than mechanical ventilation.
Dr. Jayant has asked how you escalate your inotropic support in a child who is term baby with PFH and with shock. Yeah. That also I think you have briefed in your talk.
Well, yes, but this is an important question. This is the part where, you know, an algorithm is not really available, and different people will give you different ideas. What I tend to do in this situation, and most of them with cardiac dysfunction, I start some dobutamine. If that doesn't work, I stop the dobutamine and start adrenaline. I usually work with 1, maximum 2 catecholamines at the same time. I don't just add everything together. Maximum 2. And if it still doesn't work, then you add some hydrocortisone because the receptors can be downregulated. If after you dobutamine and adrenaline and it still doesn't work, you got a big problem. I'm not quite sure if the babies then will respond to adding other medications, but then it becomes a trial and error situation. With every change, we then do an ultrasound or other measurements to make sure to see what the responses are. But our experience is, if you have a baby who is in shock and you can't get him out of shock with your first and your second line inotrope, and then even with some hydrocortisone, the outcome is generally pretty poor.
Dr. Kishore, you can ask.
There is a question from somebody who is anonymous saying, what is the target PCO2 in these patients so that seizure will not develop? I'm not sure whether you can answer, but...
Yeah, so look, for CO2, we would start to stay into the normal range, so 35 to 45. And we will accept some permissive hypercapnia up to 60. And indeed, we will be more challenged to go with lower CO2 than higher CO2s. These are babies with significant autonomic dysfunction. So their breathing regulation is also disturbed. So sometimes the CO2s go low, but whatever you try to do, even, take them off the ventilator, put them on CPAP to get some more sort of PEEP, are not always beneficial to getting the CO2s within the normal targets because of their dysfunction of breathing regulation.
Yeah, everybody, there seems to be a lot of people asking, do you prefer vasopressin or norepinephrine in the treatment of this sort of babies?
So, yeah, my favorite is noradrenaline. I know the Canadian group has vasopressin as their favorite. I'm starting to play a little bit more vasopressin, and I guess with a lot of these medications, that's probably in neonatology. We've been, all been given dopamine for such a long time, and you get used to the medication. You like to give, you know what happens. But once you venture out and start using these other medications a bit more, you will see the benefits. So noradrenaline is still my favorite if I have to use a vasopressor. But vasopressin, particularly if contractility is okay, might be a better solution.
So Koert, I know it's a difficult question to ask. If you manage the cardiovascular compromise early on, have you prevented therapeutic hypothermia to any extent, or is that independent of this?
No, we would always continue our hypothermia. There is some cases with very severe PPHN where we will stop the hypothermia, but just for a moment till we can get the PPHN back under control. I found in this particular situation, the PPHN is different than, say, diaphragmatic hernia or, PPHN due to other reasons, that if the acidosis sort of gets better, then the PPHN resides quite nicely as well. So there's a higher likelihood that the PPHN will reside. I find their response to nitrics the same for others in newborns. About 40% is a responder, up to 60%.
There's some, Ayman has asked a question. Is there any prognostic value of arterial oxygenation in HIE babies undergoing cooling?
Arterial oxygenation. Like the oxygenation index, or because look, there are all the studies which show that if the oxygenation index goes over 20, that the mortality is higher. These studies are all related to the severity of PPHN, and exactly what Giesinger showed in her studies, that PPHN is still an independent factor of poor outcome. And I can imagine if you still have PPHN at 24 hours of age, you are struggling. I can imagine that those kids have a poor outcome.
Dr. Uma from Chennai has asked, how do you change your management based on NIRS data?
Sorry?
How do you change your management based on the NIRS in NIRS?
So we have only had experience with NIRS in an experimental way, not even in my clinic. So I listened to the experts, and there's a couple of groups from the Netherlands. and you know, I'm born and raised there, so I talk to these guys and girls quite a bit, and they find that they can manage with NIRS, but they still would need ultrasound to give them information about contractility, because if you measure in NIRS a reduced perfusion in the early phases, you still need to find out where that comes from. Is it the vasomotor tone or is it the contractility? You still need to target your treatment. So all our treatments which we have available to support the cardiovascular function are basically can only be targeted if you know what cardiac function is. So yes, they use the combination of NIRS and ultrasound. And to be honest, that seems very attractive to me as well to do.
Koert, I know it's 11 o'clock for you in the night, so we need to ask some other question. Do you miss tulips and the white Christmas in Netherlands, or do you enjoy the sun and the kangaroos in Australia?
So the tulips I definitely miss, yeah. The white Christmas, I don't miss that at all. Because here at that same time, we can go to the beach and we have beautiful beaches over here.
I think we have answered most of the questions which is posted. And unless there are questions from Dinesh, Tomar, or anybody from the panel, I sincerely thank you for taking time out and coming and giving this lecture, especially when it's your bedtime. I really appreciate, and we sincerely thank IAP Neocon, IAP Kerala, and the National Neonatology Forum, especially the organizing team and Manoj for having given us this opportunity for moderating. Manoj, over to you. Do you have any other questions or?
Well, that was again yet another excellent talk, Professor De Waal. I get mesmerized by your talk every time. We are enthralled. The more we hear, you give newer insights and make us. You have simplified the whole concept of managing the cardiac compromise by putting three perspectives: the PPH and the vascular tone, the cardiac contractility, and then putting everything together. I know it's not that simple, but it's a massive, marvelous way of doing it. Thank you so much for sparing a time for us so late in the night. And I again invite you for our physical conference in September. Hopefully, let us see if you are able to come for that. Thank you so much, sir.
Well, thank you so much for inviting me.
Thank you. And I would also like to thank the two wonderful moderators we had who did a wonderful job. Dr. Kishore Kumar, as usual, he is a great moderator. And he has done a marvelous job. And then Dr. Dheeraj Tamar also excellent moderation. Thank you, both of you. And at the end, or rather, I would like to thank all the delegates who are with us in this series since June 2020, when we launched the series on 19 June with Professor Ola's talk on oxygenation of newborn. We had a marvelous journey so far, and we are so thrilled to get feedback from you through the emails, the various, and we are trying to adapt the webinars as per your feedback. As of now, we have more than 3,500 registrations from 67 today one more, so 66 countries, and then they all are. Probably we are grateful to them for joining, and then they can watch it during the time zone. Some of them it's available in YouTube. So they can watch it subsequently YouTube also. And one question that we have been getting consistently is that e-certificate. So we answered this previously. I would just again mention that at the end of the webinar series, we will be providing the attendance as per the policy we have published previously. So thank you, gentlemen, ladies and gentlemen, for attending today's session. We again invite you for the next session in the series. 2 weeks, exactly 2 weeks later, by Professor Daniel De Luca. That's on. This is the only topic that is not in hemodynamics in this in March and April, February, March, April. So this is on ultrasound guided surfactant administration. The timing is our usual time. Today's it was a different time, so it will be at 7:30 Indian time on surfactant administration by ultrasound guided techniques. So until we meet again, thank you all. Thank you so much. Thank you, sirs.
All right, thank you, Dr. Manoy. This was great, and there's so much attendance. It's fantastic. Yeah,
and
well done with organizing these kind of talks.
We look forward to seeing you again sometimes.
All right.
It's a small world, so I'm sure it will happen very soon.
It will happen. All right. Thank you all. Thanks for moderating.
Bye bye.
Thank you. Thank you.